My name is Dr. Hopp, Robert Hopp. I'm a dermatologist here in Kennewick, Washington at the Center for Excellence in Dermatology, and I've created a video list of informational videos for my patients, covering subjects all the way from shave biopsies to melanoma to sunscreens and everything in between. They're short, informational videos of what I tell my patients, and their instructional drawings that I've included that I think help patients understand the subject that's being talked about. So I would encourage you to take advantage of these. This lecture is on the different techniques for closing surgical defects after excision, whether they're created by the Mohs technique or whether they're created by general surgical excision doesn't really affect how the closure is performed. They both leave a defect in the skin that needs to be closed. The simplest closure that is performed is a side-by-side closure. So if we have a defect where a skin cancer has been removed and we want to close that back up, the simplest thing to do is just to close it together with stitches in what's called a side-by-side. So side-by-side is the simplest. Generally, buried sutures are put underneath the skin. That closes the wound about 90%, and then stitches are put on top, the epidermal stitches that don't dissolve. They're typically made out of nylon, and that closes the wound the rest of the way and gives the typical sutures that are removed anywhere from 7 days all the way up to 2 weeks, depending on the site where the surgery is performed. Head and neck areas heal up quicker than chest and back, and chest and back heal up quicker than lower extremities. The lower extremities are the slowest area to see areas heal up. The second technique that's used to close lesions are flaps. And a flap is just simply the removal of adjacent skin over a defect to close it. So if you had a circular defect and there's enough loose skin around it and a good blood supply, you could just make an incision like this and pull that forward, and it would close into a suture line that looked somewhat like that. Once again, there'd be some buried sutures underneath that would dissolve, and then you would have sutures on top that would come out anywhere from 7 days to 2 weeks. So flaps have the advantageous property of bringing the blood supply with them. So the skin that moves already has a blood supply in it, and that makes the survival of the flap, especially on the head and neck, a fairly good choice. The third choice, and probably the most complicated or the most difficult, are grafts. And grafts are done when there's not enough loose skin around the site to close it. Typical examples would be on the pretibial leg, which is the shin of the leg. The skin can be really tight in that area, the bottoms of the feet, the palms of the hands, up on the scalp. Sometimes it can be very, very close, very, very hard to get the skin to move enough to close the lesion, and also on the ears where the skin's adherent to the cartilage. So in those areas, skin is borrowed from an area where there's enough loose skin to close it. So let's say we had a lesion on the ear and there wasn't enough loose skin to close it, then a donor site from behind the ear, where there is a lot of loose skin, would be removed, same size as the defect, and then you would sew it into place, much like you'd sew a patch on a quilt. And since there's enough loose skin, you can close the lesion behind the ear, the donor side to side. And the graft would have to have the blood supply around it grow into the graft to support it. So when the graft goes on top of the skin, if we're looking at the skin from the side, and this is the defect where it's been removed. Let's say this is the fat underneath. Here's the epidermis. When the graft goes in, the blood supply around it is what supplies the graft so it can survive. One technique to try to enhance that is to wait a week for the blood vessels to grow in from the surrounding skin and to be ready to accept the graft when it's put into place and sewn in. And that would look something like this. So that's called delayed grafting. There would be the stitches, looking at it from the side and the fat down here. And by delaying the graft, you allow the wound bed to granulate, and granulate is just a fancy name for letting the blood vessels grow. So the three principal ways for a wound to be closed is with a side-to-side closure, the simplest and least complicated, a flap where you take skin from the adjacent skin next to the tumor and move it over, and then a graft which is taken from a side of loose skin and removed completely and then sewn into place.